Welcome everyone to this webinar on alcohol policy and harms under COVID-19 across 4 continents. My name is Claire Wilkinson. I'm an alcohol policy researcher in Sydney. I'm at the University of New South Wales. And I'm speaking to you on the land of the Bejical peoples and acknowledge that their land was never ceded. I'd like to start just giving us an overview of the webinar today. Okay, so we have 4 speakers and each will have 10 to 12 minutes to present, and then we'll have time for questions. After all the 4 speakers, we'll have all the speakers together and we'll have an opportunity to ask any further questions across the panel. I'm now going to pass over to Dr. Andrea Mohan from ICARA to give us a little bit of a welcome because they're supporting our webinar today.
Thanks very much, Claire. And I'm just going to quickly share my screen. Okay, so hi everyone. I'm Andrea Mohan. I'm the Secretary of ICARA. So we are the International Confederation of Alcohol, Tobacco, and Other Drugs research associations, and just again welcoming you to our 6th and final webinar for our webinar series on COVID-19 and substance use. We want to just thank the SSA, the Society for the Study of Addiction, for sponsoring this webinar series. It's been, a very informative and useful series so far. And today we'd also like to thank SHAP and SAN for hosting this webinar. So I just want to quickly give you an overview of ICARA and what we are about. So we were established in 2011, and we are an umbrella organization for research organizations or societies, groups across the globe who focus on alcohol, tobacco, other drugs, and behavioral addictions. And our mission really is to promote, support, and enhance research on these topics, both nationally and internationally, through various means. So through professional exchange and collaborations and other activities. And we have a focus on capacity building and peer-to-peer learning within and between countries. So our membership, currently we have around 20 organizations. It's evolving. So you can see that we have good representation from across the globe in terms of the different continents. And we have research associations covering alcohol, drug policy, behavioral addiction, addiction and the family, addiction librarians and journal editors, and several national associations in Australia and Europe. And this is just a list of our full members and associate members. And if you're interested in finding out more about these members, then you can go to our website that you see there, www.icara.info, and you can get a lot more about them from the member directory there. So if you do work in the ATOD research field and you belong to an association or network or group, there are benefits to becoming a member of ICARA. One of these benefits is that you have access to a global audience, because we disseminate a lot of information, research going out to our member organizations on a fairly regular basis. Also things like conference announcements, training initiatives, etc. So we do tweet about these things, we post up news as well on our website. So that's one of the benefits. One of the other benefits is that you'll have access to an international network, because we do get involved in a lot of networking. We share a lot of common challenges and solutions with research societies and teams, and we do that through workshops and symposia, other events. And for example, this webinar series is one type of event in which we have this international networking going on. Our next ICARA general meeting is going to be focused on emerging issues in cannabis and gambling research, and that date will be announced shortly, but it will be late 2021. And so that's another opportunity for networking if you're interested in this particular topic. And we also have guidance on shared challenges. So at the moment, we have guidance on developing policy regarding the management of relationships with commercial and other organizations with potential conflicts of interest. And that guidance is available to download from our website as well if you're interested in that. So there are a couple of benefits to becoming a member of ICARA. And fundamentally, we do believe in the value of bringing researchers together to discuss and share their values and interests. So if you have a network or a research association, you can join and meet with others and share that knowledge from with people in your own country about these issues. And if you have also, want to know about opportunities to get together and advocate with others about Atwood Researchers Institute. So this is where we come in, and we're trying to build this sort of capacity with researchers. We also know that many countries have national associations, and so we're welcoming them as members to ICARA, but also that research groups, consortia, universities, institutes are also welcome as associate members. And not all countries will have this particular infrastructure, and this is where we'd also like to help out, particularly by pairing up well-established research associations with individuals or small groups of researchers who are trying to establish such new networks and organizations. So if you do belong to a country where this infrastructure is currently lacking, you could reach out to us and we will try to help with this. So this is our ICARA board. So we have Fitzgerald, who's going to be presenting today as our president, and you could read more about our board members on our website as well. So we are looking for new board members for period 2021 to 2023. So if you know anybody who has any of the following, or if yourself are interested in becoming a board member, then please do get in touch with us, and you can contact me directly at her email address given here. So if you do have that enthusiasm for valuing and connecting of researchers, national and internationally, and you have some time to help out, then please do consider this. Just to note that we particularly welcome early career researchers as well to shadow more senior board members in their roles, so that they do have that opportunity to get some experience in this regard. So please do share, do consider as well. If you have anybody in mind, please do get in contact with us. And I'd just like to finally thank Claire Wilkinson for chairing the session today, and all of our speakers. Really looking forward to it. Thanks to Chris from Saran and Shap for helping to sort this through. So again, we can check out our website if you want to find out anything more about ICARA. You could also email me if you have any questions. We do have our Twitter handle, ICARA_global, and we'll be tweeting throughout this webinar about the main points. So the Twitter handle is, the hashtag is #ICARA-webinar if you're interested in tweeting along with us. And we really hope that you enjoy this webinar. Thanks, everyone.
Thank you so much, Andrea. And it sounds like a great opportunity. We know that COVID-19 pandemic, which continues, I don't think we expected it would have this time last year, but it's continued to affect our social interactions and daily routines. Some of the social distancing policies have indirectly affected our access or exposure to alcohol, but there's also been a number of direct changes to alcohol policy. So there's been temporary bans on the sale of alcohol, including in India, Thailand, Panama, and South Africa, and we'll be hearing from speakers from two of these places today. There's been increases in alcohol taxes in parts of India, and for many places, off-premise outlets have been declared an essential business. Just as a bit of grounding for today, some colleagues and I have done a pilot study where we looked to collect and classify all changes to alcohol controls in the first wave in 5 countries. We found 74 policies during the study period. Nearly 3/4 were expected to tighten alcohol controls, things like the closure of on-premise outlets. Just under 20% were expected to weaken control over alcohol. 82% were expected to have an immediate effect on consumption and/or harms. And most of the policy changes were aimed at the general population rather than specific cohorts. So COVID really has given us a large-scale natural experiment to inform the causal pathways between alcohol control, use and harm. There's a bit of a window of opportunity perhaps at the moment to think about which policies may continue and which might become permanent and what we want to advocate for. And there is an opportunity for international comparisons about the policy responses, which is what brings us together today. So on that note, I'd like to welcome our first speaker, which is Professor Charles Parry from the South African Medical Research Council.
Thanks, everybody. Appreciate the opportunity to speak today. As you heard, I'm going to be speaking about unnatural deaths, alcohol bans and curfews in South Africa, evidence from a quasi-natural experiment during COVID-19. I've listed the other people who worked with me on this paper. That's the DOI is listed below, and I can send it to people if they're interested. So the purpose of our study was to evaluate the impact of restrictions on the sale of alcohol and look at the duration of curfew on numbers of unnatural deaths in South Africa, and also to offer an academic analysis of the matter in the face of widespread media coverage of research funded by the alcohol industry, which sought to show that it was really the curfews and not the limitations on alcohol sales that was causing the drop in deaths and trauma. In terms of the data, we looked at death data collected by the South African Medical Research Council, my organization, and the University of Cape Town, a collaboration between the two organizations, which has been collecting data on unnatural deaths from January 2020 up until mid-April this year. But before I go on to that, I just wanted to have one slide giving you a little bit of background about the drinking situation in South Africa. This is from the WHO's Global Status Report on Alcohol and Health 2018, which showed that only 31% of adults, that's persons over 18, consume alcohol or current drinkers. But where we stand out is we're actually number 6 in the world in terms of the amount of absolute alcohol consumed per drinker per day at 64.6 grams, which is 5 to 6 standard drinks in South Africa. So a lot of alcohol is being consumed by drinkers. And this is confirmed by the data on binge drinking, where we are 9 percentage points above the global average at almost 6 out of every 10 drinkers engaging in binge drinking at least once in the past 30 days. Getting back to our study here, the slide below shows the weekly numbers of unnatural deaths in South Africa from week 1, which is basically early 2020, to week 15. And what you'll see there is the predicted number of weekly deaths. And then the forecast is the darker blue dotted line, the forecasted expected number of unnatural deaths. And this is derived using a regression model based on the Department of Home Affairs' data from 2014 to 2019. So we have 6 years of earlier data to help develop a prediction model which has got a 95% confidence interval around it. But let's overlay that now with the information on restrictions on alcohol. And what we've done is the green areas are where there is no restrictions on alcohol or a very limited a curfew. And then the redder it gets, from kind of yellow to dark red, is the strength of the restriction. So you'll see the second period is the level 5 lockdown from sort of late March last year to the end of April, which was a complete full restriction on alcohol sales and basically a shelter-at-home situation where you could only go out to buy food or go to a hospital, or if you were part of sort of certain essential jobs. And that was followed by level 3, which was a continued full restriction on alcohol, but the curfew was an 8 to 9 hour curfew. So the stay-at-home order was lifted. Then there was a break on the 1st of June, which is level 4, which was partial restrictions on alcohol. It was curbed for on consumption and more limited for off consumption during the week, and there was no curfew, and so on. So you can see we had, in this particular phase, we had sort of 3 periods of a full lockdown. In fact, we had a 4th period, which goes beyond the graph that I'm showing. So 4 periods of a total of 164 days, in fact, where we've had no alcohol to be sold at all. Obviously, you're allowed to consume it in your own home or make it at your own home. So then we fitted a model to the excess unnatural deaths. So you'll see on the previous graph, if I go back to it, you'll see at some periods, you'll see there's a drop in unnatural deaths, and in a few periods there's an excess of unnatural deaths. So it's the movement from the dark line, the black line, to the darker dotted blue line gives you excess unnatural deaths or a reduction in unnatural deaths. So the excess could be negative or positive. So we had 2 covariates, which is the nature of alcohol restrictions, full, partial, or none, and the duration of the curfew. Was it no curfew, 4 to 7 hours, 8 to 9 hours, or level 5, which was stay-at-home order? And you'll see the graph on the right, the observed excess deaths, the dark blue line jumping up and down, and the red line is the fitted excess deaths using the model, and the model explained 75% of the variation. So this is the main finding here. Let me just explain the plot. You'll see on the y-axis the weekly excess deaths from unnatural causes. These are unnatural deaths that's due to suicides, homicides, motor vehicle collisions, and so on, ranging from 200 to minus 600, which means there's a drop in unnatural deaths. And on the that's the y-axis. The x-axis is the curfews, and then displayed in the graph is where there's no restriction, which is the blue circle, and the partial restriction, which is the red circle, and the green circle, which is the full restriction. And you'll see, for example, that full restrictions on alcohol resulted in significant reductions in unnatural deaths, increasing with the duration of the curfew, and that partial restrictions had less significant effects on unnatural deaths. And you'll also notice that there was not much difference between a 4 to 7 hour curfew and an 8 to 9 hour curfew when we had the full restrictions. So the liquor industry was saying that basically it was all about the curfew and had nothing to do with the liquor sales, which I think this graph proves wrong. 2 slides for conclusions. While the bans on alcohol are particularly blunt instruments, they affected people whether they were heavy drinkers or moderate drinkers. As I've said, the argument that it's the curfew or restrictions on mobility rather than the bans on sale that averts unnatural deaths is refuted in this analysis. And in fact, we have a full a supplementary appendix which looks at various restrictions on mobility as well to counter that argument. And in terms of numbers, the full restriction on the sales of alcohol reduced unnatural deaths by between 42 deaths per day, with the 4 to 7 hour curfew, and we had 74 deaths per day reduced, unnatural deaths under the full lockdown. And probably the upper limit of 74 is in fact the upper end of the range, because it was the ban on alcohol was introduced very suddenly and there was no time for a black market to get going. But the main conclusion is that partial bans on the sale of alcohol were of questionable efficacy in reducing unnatural deaths. And these were, banning people from drinking on consumption establishments or substantial restrictions on the hours and days of sale for off-consumption sales of alcohol. There was also clear evidence of the link between alcohol and unnatural deaths. Obviously I've been talking about that, but it does suggest that this is obviously not a strategy, a policy we can continue in the long term, and that we really need to look at other restrictions on advertising, for example, banning advertising except at points of sale, limiting the quantities people can buy, because sometimes people are buying it at a registered outlet and then selling huge quantities through unregulated outlets. Also, the volumes we found through our research, the International Alcohol Control Study, that when people buying it from larger containers, there's much more likely to be heavy drinking. So we're also proposing that, and minimum unit pricing. And we just had a paper come out of that with colleagues at Sheffield University last week. In terms of limitations, clearly we only looked at unnatural deaths, but another study that I was part of that came out in the South African Medical Journal this year, looking at one hospital and the effects on trauma, found very similar findings, that it was the full banning of alcohol sales that had the impact on trauma, and the partial bans did not have a statistically significant impact. And clearly, while the quantum of unnatural deaths averted might not materially reduce the burden faced by COVID surges, certainly unnatural deaths is the extreme end of the trauma spectrum, and so certainly you can expect a decrease on the burden of hospitals from this study. We didn't look at the knock-on effects, such as the economic effects in terms of losses of excise taxes. The industry claimed huge drops in revenue, but in fact, the data from their reports have been showing from, for example, SAB and Heineken and Distell, found that through certain quarters or 6 monthly periods, they actually saw an increase in sales. We didn't look at, obviously, knock-on effects in illicit trading, and that's something to look out for. And my last slide, just leave it up quickly for a minute. We learned some various lessons, and just to run through them without going into details, it exposed the culture of heavy drinking. Particularly, it drew attention to the burden of heavy alcohol use on trauma in South Africa. It was interesting, the president said that alcohol is not an essential product, which was good to hear. It showed that change is possible, although obviously this is not the kind of thing we're recommending long term. It raised questions about the society we want to live in, exposed weaknesses in our alcohol regulatory environment. It showed lengths the industry would go to get their business back, but that's a story for another day. And clearly it highlighted gaps that we need to address. And we're now looking into better measurement of alcohol-related trauma. Thank you.
Thank you so much, Charles. I'll start us off, I guess, a bit of a question about the curfews and the argument from the industry. Was the difference in the curfew, I'm wondering if the curfew covered the time while people were sleeping?
Yes, the curfews generally, if it would go from sort of 8 p.m. at the most, 8 p.m. to sort of 5 a.m. in the morning. So, but obviously, so it was cutting out times when people, the early evening and also the very early morning, when you often get a lot of alcohol-related trauma and injury.
Mm-hmm. And then the second question, I'm wondering about, so policy recommendations about the partial restrictions, whether your study differentiated between, I think I understood there were partial restrictions on the on-premise was there partial restrictions on off-premise as well?
Yes. For a long time, we often only were able to sell. In fact, currently you can only buy alcohol Mondays to Thursdays from, I think it's 9 to 6 p.m. In fact, when we came out of the hardest lockdown, we did find if I go back, I don't want to go back to the graph now, but it did find a slight effect for the restrictions on off-consumption sales. I think it was 11% drop in the unnatural deaths when we had the first lifted the complete sales ban. So it would indicate that you might get some effect from restricting off-consumption sales to say 3 to 4 days per week and limiting the hours, say 9 or 10 o'clock in the morning till 6 p.m. Yeah.
Okay. Just looking through hands, and of course people can absorb and come back to questions at any point, and we'll have time at the end. So there were restrictions on days of the week. Were there any restrictions on quantity?
No, they never got around to that. We talked about that. We tried to get the government to say, look, now's the time to bring in other interventions like controls on marketing. You shouldn't be marketing alcohol during a pandemic, or controls on container sizes, saying let's try this and an experiment and say you can't buy beer bigger than 750 milliliters and things like that. But the government really only seemed to have 2 or 3 tools they were willing to try, which was off-consumption restrictions, on-consumption restrictions, or complete bans. So it was unfortunate. Yeah.
Okay. Thank you, Charles. Our next speaker is Abhijit Nadkarni, who's from the London School of Hygiene and Tropical Medicine, but is joining us from India. And I'll pass over to you, Abhi.
So I'm going to take a slightly higher level perspective of what happened in India at a couple of and continuing lockdowns since the pandemic started. And the provenance of this title that I have for my talk here comes from a real experience that we had at our home when my mother asked one of her housekeepers a few weeks back whether she had taken the vaccine for COVID, and then she said yes, but her husband was refusing to take the vaccine. And the explanation that he gave for not taking the vaccine was basically that he drinks alcohol every day, and his rationalization or his logic was that alcohol, we use it as a hand sanitizer because it kills the virus. I drink alcohol, I'm not going to get infected by it, and hence I'm not going to take the vaccination. And this is just one of many stories. I mean, this is another example which was reported in the Independent, again, for similar kind of stories. So this is just one of multiple stories around alcohol and COVID, some of which, or rather many of which, led to disasters, as I will talk about shortly. But it's difficult to kind of tell you these stories coming from India unless we foreground this against some of the epidemiological peculiarities of drinking and drinking problems in India. And one of that is this long-held myth that India is an abstinent culture and that Indians don't drink. And this is something that I used to come across quite a lot, say a few years ago when I would go looking for funding to do my research in India. And be interviewed on panels where people would say, but why should we give you the money? I mean, India is an abstinent culture. There's no need to do this kind of research. But that's far from the truth. I mean, if you just look at this one picture where we're looking at the change in alcohol consumption over a 5-year period, we'll see that for most parts of the world, the alcohol consumption has either stabilized or is going down, especially in some developed countries. But India is one of the very few countries where the per capita alcohol consumption has been going up. It's not a very recent slide, but there's no reason to believe why this might have changed in India. Indeed, the recent numbers do attest to the fact that alcohol consumption continues to go up. The other common refrain that we get is, from Indians that we do drink, but we don't have drinking problems. We don't have alcohol use disorders. This is far from the truth again. I mean, the epidemiological pattern in India, especially amongst male, is quite problematic. So although the prevalence of alcohol consumption is low as compared to a lot of developed countries, the proportion of alcohol use disorders amongst those who drink is extremely high, with almost almost half of the people who drink having drinking problems. And the epidemiological pattern is characterized by male drinking, drinking of spirits, daily under-socialized solitary drinking, large amounts of alcohol consumed within small periods of time to the point of intoxication with an expectancies of drink-related disinhibition. And then the final nail in the coffin, so to say, when it comes to alcohol use disorders is the huge treatment gap for people with drinking problems. So for every 100 people who have alcohol use disorders, almost 90 of them will not have access to any kind of care for their drinking problems. I'm not talking about high quality evidence-based care, I'm just talking about contact coverage or just any kind of care for their drinking problems. So foregrounded against this epidemiological pattern, when the COVID-19 pandemic struck India and measures were taken to reduce the spread of the virus through lockdowns and social distancing, there are bound to be some disastrous effects. Through these pictures, we see some of the things that happened when the first lockdown was announced early last year, when there was a mad rush to consume alcohol, and any precautions such as social distancing, etc., were thrown to the wind. The second time something like this happened was when the lockdown was eased, and you had hordes of people descending on places where alcohol was being sold to access alcohol, and again, any social distancing was thrown to the wind. And we had pictures like this coming out of India, where the police had to resort to lathi charge to disperse people because people were just not willing to maintain any kind of social distancing norms while they're waiting to purchase their alcohol. And then there was this frankly ridiculous pictures, one of many to come out of India, where you see this person when lockdown was eased and alcohol sale resumed in one state in India, where this person is actually, after buying alcohol, venerating in front of the alcohol and doing what we call as a puja or a religious ceremony before consuming alcohol, which would have been funny if not the sad outcomes that came out of some of these stories. So looking very closely at some of the things that happened across many parts of India, because there was no consistent policy response across the country, because some of these issues were under state control, there was a huge variation in some of the responses that happened across various parts of India. So for example, in some parts of the country, liquor was marked as an essential good, as compared to a lot of other things. So that there were situations where people did not have access to essential goods such as food items or items of regular use, but alcohol was more easily accessible. Some states took the extreme step of shutting down all liquor stores and bars/pubs in the state, whereas others kind of tried to take a more measured approach, such as having special passes for drinkers or by producing a doctor's prescription to purchase alcohol, which was immediately stopped by the state high court as seen as not an appropriate response to the pandemic and was seen as something that could result in more problems with regards to social distancing measures. All of these inconsistent responses led to a lot of problems, not the least which was alcohol withdrawals happening to a lot of people who were having alcohol dependence and were no longer having access, one, to alcohol, but on the other hand, in a context where people in the best of times do not have access to good medical services for alcohol use disorders. When people go into alcohol withdrawals, in this case, people did not have absolutely any access to services, and people went into severe alcohol withdrawals. There are stories and there are reports of people committing suicide arising out of the frustration and desperation resulting from the alcohol withdrawals. There were accidental deaths that were reported because people resorted to consuming hand sanitizers when they went into alcohol withdrawals and desperate to get alcohol. In all of this, the illicit alcohol market flourished, and a lot of people had access to illicit alcohols, which again led to a lot of issues, including deaths because of consumption of illicit alcohol. This led to several dilemmas at both individual level care as well as policy. The first one being access to care. When access to alcohol was stopped because of the lockdowns, many people went into withdrawals, but they did not have access to any care. the limited services that were available were no longer available to people because people were focusing, or health systems were focusing on providing care for people with COVID, and rightly so. But at the same time, the responsibility to provide care for people who were going into withdrawals was not taken care of. At an individual level, as we all know, when we are those who are providing clinical services or psychological interventions, we know that autonomy and agency forms a very important part of wanting to stop drink and then continuing forward with recovery. When that is taken away from people through measures such as lockdown, it has major implications on recovery, and that was seen to happen at the clinical individual level. There were implications to domestic violence because on the one hand, people were not able to go to work, were cooped up in small homes and had access to alcohol. Cabin fever set in, and domestic violence, reports of domestic violence went up. There were issues around effectiveness of prohibition. We know from evidence from India and other parts of the world that prohibition doesn't really work. And that was the same case here in India as well. There were parts of the country where there was effective prohibition because of the lockdowns, in others where it was easily accessible, and the issues that arose from that. And finally, a very big issue or ethical dilemma, which is related to policy making, the conflict of interest for the state. In India, the state has equal responsibility for both providing healthcare for people, including people with drinking problems, and at the same time, they draw huge amounts of revenue by the excise that they charge on alcohol. So there's huge conflict of interest. On the one hand, you are raising money from alcohol, and on the other hand, you have responsibility for care for alcohol. And this conflict of interest played itself out during the pandemic when the rules and regulations around control of alcohol changed rapidly and inconsistently based on excise requirements of the states. On this background, a little bit about an online survey that we continue to run in India. We have to kind of take this with a little bit of understanding that there's bound to be a bias in this data because of the online nature of this, and there's going to be some amount of self-selection when it comes to looking at the data. This data did not come from our survey. This came from the magnitude of substance use survey, which was recently done in India. And as you see from here, 17% of the population, adult population in India, consumes alcohol. What we found from our survey was 72% of people were consuming alcohol during the period that we were running this survey, and all of this was during the pandemic. Even if we were to kind of account for some of this as a result of bias of a self-selection of an online survey, we still see that the alcohol consumption is going to be higher than what you have in normal times before the pandemic started. Similarly, we have evidence from pre-pandemic when we know that approximately 40% of male drinkers have alcohol use disorders. What we are seeing here is the proportion of alcohol use disorders, or for that matter, risky drinking amongst people who drink, was not as high as we were seeing before the pandemic. Again, something to see against the bias of having an online survey. And finally, a self-report question about alcohol consumption and change in alcohol consumption in family members who are drinkers. And we saw that most reported that alcohol consumption had either reduced or remained stable, and a relatively smaller proportion of people reporting an increase in alcohol consumption during the pandemic. And finally, just talking about some potential solutions at the pandemic, at the individual level, which came into their own during the pandemic. These were solutions that we were implementing even before the pandemic, but had very huge relevance during the pandemic. One was the delivery of alcohol use disorders interventions using non-specialist health workers. In a situation during the pandemic where access to formal healthcare services and specialist healthcare services was extremely limited, delivering interventions for alcohol use disorders using non-specialist health workers, for which there is substantial evidence of effectiveness, came into its own. Secondly, the use of technology. We were running a program on telemedicine, specifically for people with mental health problems, where people could access a psychiatrist sitting at their homes or from the primary health care centers. And this again came into its own, where we were able to provide services for people with drinking problems where where they were sitting at their homes, and the psychiatrist was in the clinics, far away from where they were residing and far away from the communities where they were residing. And finally, something to think about, not very advanced technology, but an intervention that we developed to deliver brief interventions for people with hazardous drinking using text messaging. In its nascent stages, early days yet, but there were preliminary findings suggest that these intervention, which is potentially scalable, is acceptable, feasible, and does seem to have some preliminary impact on reducing hazardous drinking in India. So with that, I would like to end by quickly kind of summarizing that the pandemic situation in India did have an effect on alcohol consumption and alcohol use disorders. The responses that were put in place in terms of policy and health systems were not appropriate to a large extent, were not adequate, and did in many cases lead to more problems than solving the problems. But at the same time, looking forward, we do have various innovative solutions which we could put in place looking forward to reduce the impact of this alcohol use disorders and the impact of alcohol use disorders in people's life when lockdowns happen through some innovative solutions.
Thank you, Abhi. Okay, Peter Rice, I can see your hands up. Go for it.
Yeah, thanks. That was a really interesting paper. There was other interesting paper from Bangalore who had a lockdown looking at the admission patterns for alcohol withdrawal to the local hospital, which typically ran at about 3 to 7 a day, every day, and had done for years. And during lockdown, they had a peak of admissions for about 5 days. And then after that, this regular workload disappeared altogether. So in other words, the workload basically behaved as you would expect from alcohol withdrawal, that as alcohol disappeared, or effectively disappeared during lockdown, by 7 to 10 days, that typical workload was down to zero. So I guess the point I'm making is that while of course there's an interest in short-term increases in alcohol withdrawal, there's an interest in the risk of non-beverage alcohol. In fact, the everyday workload was really significantly reduced. I think Charles' work has showed the same in South Africa. So I think we shouldn't lose sight of that while looking at the unusual things that from this Bangalore study, and I'll send the link to Chris, it looked as if that had a significant effect in reducing a substantial workload for those local hospitals.
If I may quickly respond to that, I mean, I think while we need to keep sight of the fact that the workload did reduce when it came to alcohol withdrawals, all of that cannot fully be attributed to the fact that people went through the withdrawal process and were no longer drinking. We also have to remember that it's after the first hard lockdown, access to alcohol also became easier in India. Even when there was partial lockdowns happening, people were getting alcohol delivered to their homes, etc. And hence, some of the kind of reduction in withdrawals and some of the reductions in access to healthcare services for that did happen because people were again getting access to alcohol. Thank you.
There's one other question, but I'm going to hold it over until the end. That's from Harpreet. Thank you. So I'll come back to your question after we've had all our speakers. Next, I'm going to ask Dr. Sarah Kellenen from the Centre for Alcohol Policy Research in Melbourne, Australia, to present to us. Thanks, Sarah.
So I'm going to be talking to you today about shifts in alcohol consumption during the COVID-19 pandemic in Australia. And I'd just like to start off by acknowledging that I'm currently sitting in the land of the Wurundjeri people and that their sovereignty over these lands was never ceded. So I thought I would start off with just a bit of background about COVID in Australia, because the waves that we had are relevant to the results I'm going to be presenting. And I'm only talking about 2020 here. So we experienced relatively few cases of COVID-19 here in Australia, partly due to geographical luck and partly due to very strict lockdowns when we did have outbreaks. And as you can see here, we sort of had two waves in 2020 with some very fortunate periods of, basically hardly any cases in between. There was one wave that affected, the whole country, and the whole country was affected. And then there was a second, much larger wave that only occurred in one state in Australia, in the state of Victoria. So the first wave, in our lockdown from March 29 until May 16, we're only allowed to leave our homes for the 4 reasons. That was healthcare, exercise, shopping for essentials, and essential work and education. And schools were closed, parents needed to homeschool. In the second wave, which was just in Victoria, so for most of last year, most of the other states after that first wave lived relatively normal lives. There were still some restrictions on premise density and things like that, but no lockdowns. But in Victoria, from mid-June to mid-October, there was an extremely strict lockdown, as well as the 4 reasons. There was also a curfew. You couldn't move more than 5 kilometres from your home. There was a mask mandate anywhere outside your own home, and a permit system for essential workers. And the easing of these restrictions was extremely slow, and life didn't return to COVID normal until local transmission had ceased. During this period, bottle shops remained open. However, before lockdowns were announced, there was often panic buying anyway. Many restaurants and bars delivered alcohol or sold it for takeaway during the lockdowns to stay afloat. And requests for help seeking also increased during the pandemic. So alcohol treatment services did receive more calls for people asking for assistance with themselves or loved ones and requests for treatment. So we ran 2 longitudinal studies throughout 2020 to assess how alcohol consumption shifted in Australia in response to the pandemic. In both of these studies, we recruited convenience samples through ads on Facebook and Instagram. The inclusion criterion were being Australian, aged 18 and over, consuming alcohol at least monthly. This meant 2 main things to keep in mind when you're looking at these results. One, that our results aren't representative of the Australian population because we used a convenience sample. And 2, a lot of our results on average consumption are a bit higher than you would expect because we don't have abstainers or intermittent drinkers bringing the average down. Study 1 was very opportunistic. We actually had something going out in the field in March when everything started to, break here. And so we quickly requested and we were able to change the audit. So we asked it twice, once for 2019 and once for the month prior to the survey. We ended up getting 1,700 participants, nearly 2/3 were female, and we asked them the audit, and we also asked them the stress subscale from the DAS and some demographic items. This is as far as those 2 waves go that we had here, this is when this survey was administered. We were still very much in lockdown at this point. And what we found was overall people drank more often. They reported at least drinking more often, but they reported drinking less per occasion. They reported drinking riskily less. And because of that, the scores on the dependent subscale and the harms questions that we could ask in the survey also decreased with one exception. So people were drinking more often, but they were drinking less when they did. We did look into these results in more detail, and I've got links to the paper at the end. But one result that I just thought I would share with you is that we were interested to see if we could find any indication of what was going on with the increased calls for treatment in our data. And the one thing we did find is that people who reported high levels of stress throughout the pandemic did report an increased score in the dependent subscale of the audit. And that's the subscale that's got the close link to, needing treatment and so on. In terms of study 2, this study was written more specifically to assess drinking during COVID in Australia. We got 2,400 people, 43% identified as male, and we had all our questions about alcohol consumption were location specific. So we asked people about their consumption in 2019 and in 2020, we asked them about where they drank their alcohol as well as how much, and we asked some other questions along the way as well. Again, this survey was administered here and we were still in lockdown at this point. And so when they were looking back at the past month, they'd been in lockdown that time. And so what we found is very much in line with research we have done with representative samples in the past in Australia, approximately 2/3 of all alcohol consumed in Australia is consumed in the drinker's own home. And that's what we found in 2019 for this sample, even though it was just the people who were drinking at least monthly. The other quarter was being consumed in other people's homes, licensed premises, and in public. And in 2020, in wave one, where I showed you the arrow, home drinking did increase, but it did not increase enough to compensate for the fact that you weren't able to drink or shouldn't be drinking in those other locations, particularly the loss of being able to drink in licensed premises. We then ran the same analysis again, but we stratified it by gender down here and also by age. And what we found is that the most interesting sort of group here was the young men. This was the group of people who consumed the least amount of their alcohol in 2019, or the lowest proportion of their alcohol in 2019, inside their own home. So it kind of makes sense that these seem to be the group that was the most affected. If you're drinking less in your own home in 2019, and then that's the only place you can drink, you might have your drinking more heavily affected. And so even though their home drinking did increase quite a bit, it didn't increase enough to compensate for the fact that they weren't supposed to be able to drink in any of these other places. However, in all our other demographic groups, roughly speaking, people increased their home consumption enough to compensate for the fact that they weren't able or weren't supposed to be drinking elsewhere. In terms of our more longitudinal results, and I cannot stress enough, the results I'm showing here are very preliminary. We haven't cleaned our data properly or accounted for attrition here. And I'll let you know at the end where you can see our much shinier and probably better results when they're available. But what we have here is we asked people to continue filling out the same survey throughout the pandemic. And so these are the waves where we ask people to continue asking the survey. I'll just go back for a second. In terms of the lockdown in Victoria, in wave 3, wave 4, and pretty much wave 5, Victoria was in lockdown. There was some restrictions being loosened at wave 5, but it was still actually quite strict because local transmission hadn't ceased yet. So it wasn't until wave 6 where Victoria was as free as the rest of the country, really. And as you can see here, in wave 1, as you saw in the other graph before, drinking in the home shot up, between sort of 35 and 40%, depending on the state. And then when we got to these waves 3 to 5, where Victoria was in lockdown, but the rest of the country wasn't, home drinking came up again, but it was really sort of hovering even slightly lower than it was in the previous waves outside of Australia. In terms of drinking in licensed premises, during the first lockdown dropped, as you would expect, nearly 100%. But in Victoria, it stayed very low. But in all the other states that reported, despite density limits and so on being in place in some of those places, it nearly bounced back up. We think some of the declines down here are about attrition. And so, these results are preliminary, but we're sort of finding that it does look like people were bouncing back to their previous habits. So overall, we do think that during the lockdowns anyway, Australians may have decreased their harmful drinking, particularly among young adults. This is despite an increase in how often people were drinking. I kind of think that the decrease in young adults was probably more about where they drank in 2019 than anything to do with their age. But something we're keen to really look into, particularly for the Victorians, that we've assessed is whether or not this more frequent consumption in the home is a habit that's harder to shake, especially if it's something that you did for that longer Victorian lockdown. Home drinking is thought to be very habitual. It's not something that we think about a lot. It's kind of just something, there's times of the day or night that people have a drink, and it's not something that is as purposeful, I think, as drinking in licensed premises in other places. And so one thing we're really keen to follow up on and see is, particularly with the Victorians, is if you increased your home drinking, how did you go in bringing that back down again when you were able to drink in the pub or in your friend's house or so on and so forth. So that's something we're really keen to look into. What we didn't get is much to indicate why there was that high increase in requests for treatment. We think that's partly that this particular study probably wasn't well suited to picking those people up. The people looking for treatment tend to be the pointy end of the distribution, and a sort of big general convenient sample might not be picking up those people well. However, we did sort of get some idea that it might have been, stress, pandemic related stress, which is a pretty reasonable hypothesis there. Limitations, it's a convenient sample. Like I mentioned, we were a bit concerned about attrition, particularly towards the end, and also regression to the mean. I'd just like to acknowledge my co-authors quickly, particularly Yvette Mojica-Perez, who did a mountain of work on this study. She's doing her PhD on this data. So when I said we're going to have better results in the future, it's not because I'm going to be doing it, it's because Yvette's going to be doing it. And I strongly recommend you look out for her work because I think it's going to be excellent. We do have 2 papers out from these studies so far, but Yvette, I think in particular, will be putting out more in the future. Thank you.
Thank you very much, Sarah. I know her, sorry, personally, that's my nickname for her. There's one question here. I will say Yvette, who Sarah mentioned, is going to write a blog post as well following this session, so that we can do a link to that as well. So Dr. Addy, I'm going to save your question till the end because we can ask it of all 4 speakers. Sorry, pronunciation, Elsa Rutter, for Sarah. Have you got alcohol-related deaths data yet for Australia?
If we have, I haven't seen it. Not to my knowledge, no. We'll be really interested to see. I'm hopeful that the kind of and I think some other studies were finding similar patterns, but if what we found in our convenient sample is representative, I'd like to hope that maybe we might get a reduction, but then what the calls for treatment and so on might indicate that might not be the case. But fingers crossed. I
wanted to ask about the persistence of home drinking following a period of lockdown. And the question is, I think, so your study will have the ability to compare people who were in lockdown in New South Wales, which was a much shorter period than those in Victoria. And you could look at the effect of length of lockdown on persistence of consumption pattern changes.
Yeah, we're really keen. We're really keen to do that. I think it does look like outside of Victoria that things bounced back fairly well. So that's a good sign, at least in our sample. But with the longer lockdown in Victoria, we're quite keen to see if that's what's happening there. And of course, that would have ramifications for, say, Sydney in 2021. It really is the work we've been doing on home drinking at CAPR, the one thing that comes through is people don't really think about it, and they don't, it's just a lot less deliberate. And because of that, I am concerned that if you get into the habit of drinking every night, even if you were drinking less per occasion than you were when you were able to go out, if you then have those weeknight regular drinks that you weren't having before, and then you're able to go out on the weekend as well, once you're free again, that can lead to higher total consumption. So, and then all the harms that come with that. So that's something we're particularly keen to keep an eye on, and we're really keen to assess and also using, other data sources when they become available as well, obviously.
Okay, and thank you to Chris, who's putting links to the papers that Sarah and Yvette have authored from Australia in the chat. Okay, so I'm going to move on to our final speaker, which is Professor Niamh Fitzgerald from the University of Stirling. Thank you, Niamh.
Thank you. Hopefully you can see my full slide now. Thank you very much. Really interesting presentations so far, which have really set the scene for what I'm talking about. But I'll just give you a little bit of background on the situation in Scotland and England, where our studies are based. So both had a full lockdown with closures of on-trade but not off-trade premises from late March 2020. But the reopening dates and the restrictions and the operations that existed after that time, so from around May, June, were very varied varied both within and between Scotland and England. So just as an example, nightclubs have been closed throughout the pandemic period in Scotland, but in summer 2020, when on-trade premises were permitted to reopen, nightclubs were still closed, but late bars were permitted to open in some cities, but in other cities there were voluntary agreements to close at midnight. And as another example, a curfew in autumn applied in England around 10:30 p.m, though it varied, but shops were still allowed to sell alcohol for 24 hours, whereas in Scotland, both pre and during the pandemic, off-trade sales stop at 10 p.m. So where there were curfews in Scotland, there wasn't the opportunity to immediately go to a shop and buy alcohol after you left the pub if there was a curfew. And what we're also seeing, which is one of the motivations for our paper, is a pressure to liberalise opening hours as part of a narrative around recovery of on-trade premises and the suffering of on-trade premises, and a need to therefore liberalise in order to help those businesses to recover. And we're already seeing significant developments in liberalisation of opening hours in the Republic of Ireland and in Northern Ireland, and discussions along the same lines in the rest of these islands. So just going to present today on 3 research questions from 3 studies. I'd like to just acknowledge the team of people who've worked on these studies and our funders, the Scottish Government Chief Scientist's Office and the National Institute for Health Research in the UK. We're going to look at how the pandemic might have shaped regulation of alcohol sales through the licensing system. We're going to look at how ambulance clinicians' experiences and views of alcohol-related call-outs, how they felt call-outs had changed during the pandemic in Scotland, and then specifically looking at quantitative data on alcohol-related ambulance call-outs during that first national lockdown from March onwards. So this is opportunistic data that we're analysing from studies that were already underway, and I'll mention very briefly some of the limitations from that. The 3 studies that we're drawing on are a study that's looking at alcohol premises licensing, the overall study draws on data from 40 diverse local authorities across England and Scotland, and the pandemic relevant interviews are 16 interviews with diverse stakeholders within our alcohol premises licensing system. The second study is also qualitative. It is set up to look at the impact of alcohol and minimum pricing of alcohol on ambulance call-outs in Scotland. And again, we conducted during the pandemic 15 in-depth semi-structured interviews, this time with ambulance clinicians, paramedics and paramedic technicians. And the third study was a study specifically set up, funded by the Chief Scientist's Office, also to look at alcohol-related ambulance call-outs during that first lockdown period. And that is based on a descriptive analysis that I'll show you, but we identify alcohol-related calls through a button that paramedics can select on the patient records when they're recording their call-outs, but also with an algorithm-based search of free text entries that is much more sensitive in picking up alcohol-related call-outs, and you can read more about that in our paper. So firstly, just to present some of the qualitative data from our licensing stakeholders. So the stakeholders felt that the liberalisation in local licensing and other changes in alcohol licensing policy favoured some businesses over others. So they talk about where reopening was permitted initially in outside areas only, in outdoor areas, and indoor areas were either not permitted to open or later not permitted to serve alcohol. Then you see the premises expanding their outdoor areas. So the quote here saying everybody needs to turn everything into a beer garden, car parks, the street outside, everything. And so you see this expansion in outdoor areas. You also saw, particularly in England, a national decision to permit all on-trade premises to sell takeaway alcohol, and this combined with lack of restrictions on drinking in public, which we have in some parts of Scotland, meant that people could wander around the streets with pints of alcohol in plastic pots, which was not permitted previously. And overall, the licensing stakeholders felt that there were businesses that benefited from this. Clearly, off-trade sales increased in the UK during the lockdown, but there were also some that they felt really suffered. So small corner pubs, live music venues and nightclubs were particularly felt to be affected. When we look at the qualitative data from the ambulance clinicians, it's striking that they note this huge reduction in alcohol-related call-outs that they experienced as not being replicated by home drinking call-outs for alcohol. And what we see here is their descriptions of kind of the pre-pandemic being just such a huge level of public intoxication and mass intoxication, and that they just didn't see this when pubs and nightclubs were closed. They report seeing much less in the way of assaults that involve alcohol. You see here falls and all of these things. They talk about this massive drop, and they describe this as being really welcome. And I think it's quite striking here, picking up on some of Charles' points from earlier, just the kind of level of pressure on ambulance call-outs that you can see in this next quote here. That was in place prior to the pandemic. So they say it's just so nice to go to work on a Friday night and know that you don't have to go into pubs and clubs. It's made this huge difference. And they do describe some occasions still where you get parties or illicit parties during lockdown where people are still drinking, but not this war or battlefield environment, and really welcoming that. I think quite stark comments there about how it was previously. But they did raise fears, echoing Sarah's comments, that home drinking habits might persist. They were particularly concerned about some subgroups, those with alcohol problems or those living in difficult or abusive relationships. So I think they talk about people might get used to being in the house drinking. So why get dressed and go out when I can just sit here and watch TV and do what I've been doing for the last 7 months? And the sense that all of these people can't stay at home drinking without a consequence at some point. So quite qualitative reflections from the paramedics, but they're going into people's homes and I think seeing what's happening in people's homes. So it's quite interesting to see their views. So the third study is quantitative data. So what I'm showing you here is not alcohol specific callouts. This is all callouts, and what we see when people are staying at home, and also with a fear of attending hospital being a real feature of the kind of public discussion during the first lockdown. You see a drop in the total number of ambulance callouts for any reason between March and June 2020. So particularly in April, May and June, just over 10% reductions in all ambulance callouts during that first lockdown. But what we see when we look at the alcohol-related callouts is a much bigger reduction, especially in April. So we see particular falls in alcohol-related callouts driven by a fall at weekends. So when you look specifically at Friday to Sunday callouts, you see a 31% reduction in the alcohol-related callouts, whereas the reduction in other weekend callouts is only under 10%. So for non-alcohol, the ones that are not deemed to be alcohol-related. And this is even greater still when we restrict it to 8 p.m. Friday to 6 a.m. Saturday and 8 p.m. Saturday to 6 p.m. Sunday. It's not shown on this graph, but you see almost 50% reduction in alcohol-related ambulance callouts. And if you're wondering what's on the graph here, so what we see here is the red dots are the total daily callouts on each weekday. So every dot is a day total of callouts, and the blue dots are weekdays. There are some outliers here. Those are when New Year's Eve fell on a weekday. So if you're just looking back through the time series, that's what those are. So just very briefly, discussion points on this. What we see is that outdoor drinking is on the rise, and actually, as we, even since I've written this originally, I've updated this to say that this is probably difficult to reverse. Once spaces are granted licenses and once outdoor spaces are licensed, it's quite difficult within our licensing system to revoke those changes, and that carries risks, but particularly, I suppose, just an overall potential increase in availability once the restrictions on capacities within premises are also lifted. What we also see here is that a large proportion of alcohol-related ambulance callouts are linked to the nighttime economy. So this is perhaps not surprising to those of us working in the field, but I think it's important to acknowledge that prior to this, we weren't, particularly with the qualitative data, we weren't really sure what the balance was in terms of how many alcohol-related callouts are linked to home drinking, which we have, 80% of our drinking in Scotland is home drinking. But actually, the balance is not the same in terms of alcohol-related ambulance callouts looking at this data. And I think it echoes Charles' points about what do we want to return to post-COVID? Is this the kind of level of harm that we're comfortable with? Home drinking habits may persist and may have long-term consequences. It looks from our data that there are probably lower net short-term harms during lockdowns arising from alcohol, but risks, of course, for the subgroups and risks in longer term. Plus, we have seen, although it's not in our data, bounce backs in terms of overall consumption potentially rising after lockdowns, which would have some of those consequences. And finally, I think just thinking of how the on-trade sector has potentially been reshaped as a result of the pandemic, and this is still continuing. We're seeing that where smaller operators are struggling, they're being bought up by chain retailers, chain pubs. We are also, I think, more aware than previously of the interest groups being, I suppose, mixed, in that those that might be advocating for measures that would protect potentially on-trade venues, or at least not harm on-trade venues, like a rise in price in off-trade, where on-trade venues are owned by producers and trade associations are representing on and off-trade together. You're perhaps losing allies in the on-trade for some of these policies that might be those sort of sweet spot policies that might both protect public health and support on-trade recovery. And we're looking into that some more. Very quickly, limitations. The data are limited to interviews conducted after the pandemic had started. And it's also, of course, possible that in our call-out data and in our paramedics' reflections, they may not be recognising alcohol as a factor where they're visiting homes quite so easily as it might be recognisable where they are going to call-outs in bars, pubs and streets. So just to conclude then, I guess our suggestion is, and we're looking into this further in another study looking at, originally set up to look at opening hours in the nighttime economy called Elephant. We're wondering if, when policymakers are reluctant to be seen to hurt sort of this suffering hospitality sector, but they also want to protect health services, are there policies that we can find that we could agree on that would both reduce alcohol-related harm overall, but not necessarily further affect on-trade premises where they might be struggling? And so plenty more to report here, and we'll be looking into it further. The paper for this study is under review at the moment, but we'll share it with you when we can. Thank you.
Okay, if anyone wants to ask a question of Neve, if they could raise their hand or type a question. Neve, there is one question here in the chat box from Elsa, sorry. Neve, do you have any thoughts on the Scottish death data increase of 17%? Could this partly be explained by people presenting too late with symptoms during the pandemic and health services not picking up on things much earlier as not seeing the people?
Yeah, I think that's quite possible as one explanation. I think the other possibility is that data, I haven't seen it, but I'm assuming it's annual data. And so I guess what we're reporting largely is for small parts of the year where we were in lockdown, but it looks like drinking may have gone up even further after lockdown than it was. So I think it's not just what's happening in lockdown that may be explaining the deaths data, but what happens when premises are reopened as well. And I think there's also, a sense of kind of, is there a sort of celebratory or kind of post-pandemic party atmosphere that exists that might explain some of it. But I think the delay in people presenting with symptoms may also be, I think others who deal with people in sort of end stage liver failure and things like that would be better placed to comment on that than I am as to whether that sort of delay is likely to be fatal for people. But I suspect that may well be the case.
There's a second question there also, could it be also related to increases in home drinking, and are we able to unpack those two things?
It could do. There are other studies that have been published. So I know Colin Angus and others have published on some of the sales data during the pandemic in the UK. And so that's some of the data that I was referring to. But yeah, so I think our study is probably not best placed to look at the deaths because it doesn't look at consumption levels directly. It's this indirect kind of pressure on services. But yeah, there's lots to take in, I think.
Okay. What I might do then is ask all our 4 speakers to come on camera, which I can see you all. That's great. And I'm just going to jump back to a question I missed after Charles's presentation and ask Charles, and then if any of the other 3 speakers want to speak to it. This came from Ian. Up. Charles, was there any evidence for an increase in use of non-beverage alcohol given the abundance of hand gel?
The evidence was more around industrial alcohol or methanol, and that came in the form of sort of newspaper reports of some fatalities. In It was about, I mean, I counted perhaps as many as 20 fatalities over maybe about a 6-month period that occurred with people using industrial alcohol. Hand sanitizers, no, that wasn't reported at all. The industry funded some studies trying to estimate the impact on the illicit trade as a sort of a lever to influence government to say your interventions is stimulating the illicit trade, and it was more around a little bit of smuggling coming in, but it's much harder to smuggle alcohol products than cigarettes. So that there were cases of that, but not hand sanitizers.
And just to clarify, were you hand counting from like hospital data or from newspaper reports?
No, I just did it informally from newspaper reports when they sort of, but the industry was keen to make sure these got into the press because it sort of helped bolster their argument. So I don't think there was a lot of undercounting when it happened. It happened. So it might sound a lot, but if you look at how many deaths per day we have from alcohol anyway, 170 or so, it's over a long period of time. It's not as impactful as you might think.
Mm-hmm. Do any of the other three speakers have a comment? No? Okay. Abhi, sorry, were you going to say something?
Yeah, I was just about to say that there were kind of quite a few reports on hand sanitizer use as a replacement for alcohol that was not available. But again, it was not something that was formally researched. At the same time, the use of illicit alcohol did go up, and then there were several reports across various states that that was happening, which was to be expected, considering the fact that even pre-pandemic, there was, in many parts of India, there is a flourishing economy around illicit alcohol, which kind of obviously flew under the radar even when when there was a lockdown. So that did continue, or indeed flourished when the availability of alcohol in its kind of legal forms became reduced during the lockdowns.
One more thing, very briefly, we found that there were break-ins of liquor stores, which certainly got a lot of publicity, and there was a shortage of pineapples because people were making pineapple beer. So the price of pineapples went up dramatically.
We should all be monitoring pineapple sales. Okay, so Dr. Addy asked, in countries that have been worse hit by COVID globally, where elective secondary care has been restricted, what's been the impact on alcohol-induced illnesses? I'm not sure if anyone can comment on that from their work. No? Okay, we'll pass on that.
No data, unfortunately. I mean, I think it speaks to the issue of having good, recording systems which can pick up, the effect of these kind of policy shifts and the secondary impacts and things like that. Certainly, we're going to start collecting better data, I hope, on alcohol-related trauma.
And on top of having it collected, also having it made available as quickly as possible, because I don't know if it's the same everywhere else, but we can have trouble with some of this data coming out years and years after the fact.
Enya, did you want to take yourself off mute and ask a question?
Yeah, sorry, I've got a cat in the background, so she might make noise, which is why I was on mute. But yeah, I found Neve's, all of your presentations really interesting, but I suppose from my point of view, the whole thing about finding policies that address alcohol harm without hurting the hospitality sector is the real key question, I think, for lobbyists like me. So yeah, I just wondered from each of you what you would envisage some of those less kind of controversial policies and what they would look like for you.
I'm happy to start if you want, Claire. This is something that we're looking at. We've run a couple of expert workshops as part of our elephant work to explore the kind of evidence around 4 main policy areas in relation to being potentially these sort of sweet spot policies. And those are pricing policies, restrictions on online sales, sort of environmental interventions around violence reduction in the nighttime economy, potentially including restrictions on new openings, but also looking at size of premises has come up in those discussions. And the fourth one is perhaps less evidence-based, but around promoting certain types of premises over others. So food-based establishments over vertical drinking establishments. Although I think that was considered perhaps less strong in terms of its potential impact in our workshops. So we're looking to write that up at the moment, and we'll be preparing a kind of policy briefing on those potential policy areas. So my colleague Rachel O'Donnell and Isa Uni are working on that, and several of the people on the call today helped us out with those workshops, so I'm very grateful to them.
I can, our work, I think the big one is the delivery, online ordering and home delivery of alcohol, I think. And in terms of it not hurting the sector, I think it's probably less about bringing in anything that would have make a huge difference now, but rather the online delivery is kind of driving some really big holes in the kind of policies that we had in place when people had to go to a place in person. So the work of, checking IDs, making sure someone's not intoxicated, that stuff's now being left to a driver who might not have we have a responsible service of alcohol here. So a lot of that work, not to mention work that's done on availability and making sure there aren't too many premises in an area. It wouldn't matter if there's only one premise in an area for it'll deliver to your door. So I think that the big one from our work has been online delivery and home delivery of alcohol.
I think
Charles,
from the perspective, from perspective of India, I think all of these interventions that have been suggested are potentially applicable. But I think the biggest challenge in India, even pre-pandemic, when it comes to alcohol, any policies around alcohol, which we don't have a consolidated policy, but kind of independently policies at different levels. I think the issue has always been implementation. And that's where we falter. So the question for me, and something for policymakers to think about in India is not just about what are the evidence-based interventions we can put place in this pandemic. It's how do we ensure that they are implemented in the letter and the spirit, and that's where the big challenge is going to be.
Okay, shall I jump in now? I think there are a couple, and we had an article in The Conversation which picked up on some of them. I think I'll go through very, very briefly. We have various stalled legislation, and we called for that legislation to start moving. We also talked about the volumes of alcohol you can purchase without a liquor license. So if you are purchasing from an off-consumption outlet, you shouldn't be able to buy 100 liters of alcohol if you don't have a license, for example, because obviously you're going to be selling it for on sales through an unregulated outlet. Container sizes, we argued, for example, against selling alcohol in larger containers, because we've shown a link, as I mentioned, between heavy drinking and larger container sizes. So end the 1 liter and the 1.5 liter beer containers. Marketing, we kind of pushed the idea of maybe banning marketing except at points of sale, or also particularly special offers and freebies and things like that. There were even freebies during the pandemic. Minimum unit pricing, we're pushing that agenda. Drink driving, there's plans to move ahead with dropping the level to 0.02. And so we maybe said it's time to look at that. And finally, online sales, again with Sarah, we feel that it should only be delivered by a person who's an employee of an outlet having a liquor license, because they've got something to lose. Otherwise, some guy on a motorbike drops it off, he really doesn't care. And he might lose his job, but the company's not going to lose much. So that's one of our recommendations.
Charles, do you have online delivery in South Africa? That was a question from
Yes, okay. We do. And, Uber Eats can even deliver it, and, whatever, it's very easy. in fact, now they're looking at some of the petrol stations. I mean, probably trying to get money to claw back. Their convenience stores are applying for liquor license at petrol stations, which we're fighting to stop too.
Thanks, Anya. Great question. And Parvati has added, I think this is where lower strength alcohol products could potentially be useful in finding that sweet spot between the industry economy and reduced health risks. Much more research is needed. I will plug an article that's been led by a colleague, Stephanie Colbert. Chris has put the link in the chat just because it's a recent systematic review of 77 jurisdictions, given this is such an international audience, a review of policies around online alcohol delivery in 77 jurisdictions. Okay, perhaps we have time for one more question. If not, I will mention there was a question by Harpreet to Abhi about what can India do more generally around alcohol control, given a rising middle class. You touched on it with implementation. Was there anything else you'd like to add?
I think we'll need to have a big talk on this because there's a lot to be done. There's no consolidated policy, so that means that every state which has its control over excise duties, etc., on alcohol does its own thing, and so there's huge variations. Even if you look at one of the simplest, so to say, intervention about pricing. At a policy level, I mean, that's so difficult to implement because each state determines how much excise duties they're going to charge on alcohol, which means that there's such a huge variation in the prices of alcohol across the country. And then you have places, states within the country where people can come in just to have alcohol as a part of their holiday, and that becomes a big part of the vacation, etc. So I think the first step is actually having a consolidated policy, which is looking at evidence-based interventions. Everything else follows on, because as we know, I mean, there's no dearth of evidence on what works when it comes to policy. It's more about deciding what we are going to do, and also at the same time taking care of the huge conflict of interest that the state has when it comes to implementing these interventions.
Thank you. All right, well, there's lots of thanks in the chat. I'd like to wrap up the webinar by thanking our 4 speakers. And thank you, Chris, for being such a great, efficient linker to everything that's been mentioned. That's just a wonderful list of resources there on this topic. Thank you all for joining us. And we hope everyone's staying well in these times. We had someone join us from Afghanistan. So thinking more globally about what's going on, it's meaningful to have you here. And all registries will get a link to the recording of the event. And all the best for the rest of the day and or night to everyone. Thank you all.
Yep, bye-bye.
Bye-bye, thank you.
Thank you.
Thank you so much, Claire.
You're welcome.
Thanks.
Okay. Thank you so much. Thank you.